Good afternoon, everyone. Welcome to the Thursday, May 10th meeting of the Emergency Medical Care Advisory Board. I'll call the meeting to order, and I'll ask, Mr. Miller, would you mind leading us in flag salute? Yes. It's right over your right shoulder. Please stand with us. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Please have a seat. I usually do that when I come down. I'm sorry, I threw it at you at the last minute. Okay, Mr. Ferris, would you call the roll for us?
Certainly. Chief Marshal.
Here.
Kathy Prout. John Surface. Here. Chris Lyon. Here. Bruce Peters. Here. James Miller.
Here.
And Supervisor Maggard.
Yes, here, thank you.
We have a quorum.
Thank you very much. We have some items on our agenda that are consent, which means that they're relatively routine and non-controversial, so we tend to vote on them all at once. It looks like everybody in the room is a regular, but if there's anybody who's not, then we're going to vote on them all at once. So they are indicated with a CA. They're on item number 5 on the first page of our agenda. On the second page, item 12A, Roman numerals. You guys makes this harder, having to convert those. Those items are on consent. So is there anybody who has a question about a consent item? Is there a motion then to approve the consent items?
Motion.
And a second? Thank you, Mr. Peters. Please indicate your support for that by saying aye. Aye. Is anybody opposed? Okay, thank you. Then we're going to go next to there's no subcommittee reports, so we're going to go to public comments. Are there any members of the public that would like to come before us this afternoon and say anything to us that's not otherwise on our agenda? About anything that's not otherwise on our agenda? Okay, so we'll return then to our next item, which there are no public requests to make a report. There are no unfinished business, no new business. But we do have, since this is our annual meeting, we have several reports on items that took place during 2017. So item number 10A is a Resuscitation Academy report to be received and filed, and Mr. Ferris is going to read that, or have staff read that report for us.
Thank you, Mr. Chairman. I'm going to defer this report, Resuscitation Academy, to George Baker, EMS Coordinator.
Good afternoon, Mr. Baker.
So, as you know, the EMS Division monitors and oversees all facets of pre-hospital emergency medical care in Kern County, as delivered by our contracted ambulance providers and through our partnerships with area hospitals under the direction of the medical director. This care can include victims of trauma, myocardial infarction, stroke, and sudden cardiac arrest in both the adult and pediatric populations of Kern County. In the U.S., 350,000 people a year die of sudden cardiac arrest. 4 out of 5 of these occur in the home. Using the standard model of cardiac care in a pre-hospital setting, only 10 to 20% of these patients survive to discharge from the hospital with an intact quality of life. It is the duty of the EMS Division to identify areas for improvement and implement changes to the system that have a proven track record. King County Medic 1 and Seattle Fire Department have developed over many years a modified system of treating sudden cardiac arrest patients that includes many facets such as high-performance CPR, telecommunicator CPR, bystander CPR with the use of the Pulse Point program, and the public access AED. The system accounts for a 50 to 60% survival rate of witnessed cardiac arrest victims. In October of 2016, the EMS Medical Director, Dr. Lyon, and myself traveled to Seattle to take part in the Resuscitation Academy that is administered by Seattle Fire and King County Medic 1. In April of 2017, the EMS Division hosted a Resuscitation Academy at Kern County Public Health Services Department, and we have begun implementing many of the components of the high-performance system here in Kern County, and we look forward to improved cardiac arrest survival rates. Therefore, it is recommended the board receive and file this staff report.
Thank you.
Thank you.
Thank you, Mr. Baker. Are there any questions by members of the board? How about members of the public? Okay, recommended action is to receive and file. Is there a motion to do that? Thank you. Can we have a second? Please indicate your support by saying aye. Aye. Is anybody opposed? Very good, thank you. How about item number B? This is a report on the Napa fires. Mr. Ferris?
Thank you, Mr. Chairman. I'm going to defer this report to Nick Lidgett, EMS Coordinator, and RDMHS.
Mr. Lidgett, how are you this afternoon?
Wonderful, sir. Thank you. Okay, on October 8th, 2017, a group of large wildfires started to spread in Northern California. These fires affected the counties of Napa, Sonoma, Mendocino, and Solano. The North Bay fires, as they are now known, have been recorded as the deadliest wildfires in California history. The North Bay fires killed a total of 44 people and hospitalized dozens more. In total, the fires burned more than 8,900 buildings, which were largely residential structures, and scorched 245,000 acres. Due to the immense size of the fire, over 72 shelters were stood up and an estimated 5,800 evacuees were housed for extended operational periods. Among the evacuees were approximately 1,100 medical patients that ranged from critical ICU patients to the elderly skilled nursing facility type patients. The task of transporting, tracking, and supporting the shelters for the disaster proved to be extremely overwhelming for the local operational area and required a significant amount of mutual aid resources to be needed from the unaffected surrounding counties. On October 11, 2017, the Kern County EMS Division was contacted by representatives from the Emergency Medical Services Authority for mutual aid support from the Region 5 Regional Disaster Medical Health Specialists, or RDMHS. This is a position that is housed and supported by the Kern County EMS Division. The Region 5 RDMHS responded to Sacramento, California, and assisted the Region 2 RDMHS with various mission tasks based on their priority. Such tasks included coordinating the resources to evacuate the Yountville Veterans Home Skilled Nursing Facility, and securing volunteer resources that were needed to staff multiple shelters, as well as creating important situational reports that were sent to the state and regional authorities. The assistance of the Region 5 RDMHS role was deemed crucial in the proper disaster relief efforts that were needed in order to protect public safety. The California Emergency Medical Services Authority has since amended the RDMHS scope of work and to include regional mutual aid assistance whenever they deem it necessary. The Kern County EMS Division will continue to support the RDMHS role and meet all contractual demands. Therefore, it is recommended the board receive and file this report.
Thank you.
Thank you.
Any members of the public have a question about that report or a comment about it? How about members of the board? Okay, then is there a motion to receive and file that report? Thank you. Second. You catch that? Thank you. Please indicate your support for that motion by saying aye. Aye. Is anybody opposed? Very good. Thank you. Thank you, Mr. Legit. Next is an annual ALS provider performance report, or a number of reports apparently. Mr. Ferris?
Thank you, Mr. Chairman. On September 21st, 2006, the Ambulance Ordinance, Chapter 8.12, was enacted. The ordinance established the exclusive operating areas, or EOAs, that divide the county for ambulance transport services. These EOAs were assigned through the execution of performance contracts with ambulance providers. The Ambulance Service Performance Standards, which were approved by the Board of Supervisors on December 5th, 2006, outline the requirements that ambulance services must meet in order to maintain in compliance with performance contracts. Additionally, the Kern County Fire Department implemented paramedic services in the operational area of Pine Mountain Club, or PMC, on March 1st, 2009. The implementation of this advanced life support program created paramedic first responder policies and procedures, Kern County Fire Department Station 58 Pine Mountain Club policy, which also includes performance-based standards. On a monthly basis, each ambulance provider and the Kern County Fire Department are required to submit reports to the division for the monitoring of performance. The information is compiled and reported to the Board of Supervisors annually. In 2015, your board designated the May meeting as the annual meeting for review of the EMS system. The division has finalized the following annual performance reports. EOA 1, Hall Ambulance Service, Inc., EOAs 2, 4, 5, 8, and 9, Hall Ambulance Service, Inc., and EOA 11, Hall Ambulance Service, Inc., EOA 3, Delano Ambulance Service, EOAs 6 and 7, Liberty Ambulance Service, and OA 58, Kern County Fire Department. Each provider has been given an opportunity to review their respective reports and provide feedback. It should be noted, after sending the MCAB packet to the board, it was discovered that an error had occurred in the processing of the data for the OA 58 area in 2017. The data was reprocessed, and each board member has been provided with an updated annual data report. That's the report I set in front of you. With that, it is recommended the board receive and file the annual EOA performance reports. I'm available to answer any questions.
Thank you. Any members of the public have a question or comment? How about members of the board? Okay, is there a motion then to receive and file that report?
Motion.
Thank you. Please indicate your support by saying aye.
Aye.
Anybody opposed? Thank you very much. And our last report regarding 2017 is an annual EMS system activity report. Mr. Ferris?
Thank you, Mr. Chairman. Title 22, Chapter 12, Article 4, effective January 1st, 2006, mandated the local EMS agency, or LIMSA, develop a system-wide implementation of a quality improvement program for the delivery of EMS care to the public. This includes mechanisms to track quality indicators for personnel, equipment and supplies, documentation, clinical care and patient outcomes, skills maintenance and competency, transportation and facilities, public education and prevention, and risk management. Health and Safety Code 1797.276 requires the division to report to the state annually regarding the activities of this board. Furthermore, it requires the report be submitted to the County Board of Supervisors. The EMS division developed an annual report that compiles all the quality improvement activities we are involved in and ensure they meet all the quality indicators required in Health and Safety Code and Title 22. In doing so, the division has compiled numerous data elements from over 100,000 EMS electronic patient care records. It also required cooperation from local hospitals to ensure an accurate and complete analysis of our system is presented. This report accurately summarizes the effectiveness of the Kern County EMS system and the activities of MCAB. The report meets all requirements set forth in Health and Safety Code and Title 22 and follows the guidelines established by the Emergency Medical Services Authority, or EMSA. In addition to including this report in your board member packets, a copy will be submitted to the Kern County Board of Supervisors and EMSA. Therefore, it is recommended that the board receive and file the annual EMS system report for 2017.
Very good, thank you. Any members of the public have a question or comment about that? How about members of the board? Is there a motion then to receive and file that report?
Motion.
Second. Thank you. All in favor, please say aye. 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 Is anybody opposed? Thank you. Next up is item number 11, which is our director's report. Mr. Ferris?
Thank you, Mr. Chairman. 2017 was an exciting and challenging year that brought many changes to our division from the top down. The division experienced several personnel changes, including leadership changes in August of 2017 and again in March of 2018. During that same time frame, we hired an EMS coordinator, Charles Brockett, who is managing trauma quality improvement, and an epidemiologist, Margaret Mize, who is managing all of our quality improvement and surveillance data. 2017 also marked a year of transition in our data. As mandated by the state, we made the transition from NMSIS 2.2 to NMSIS 3.4. This was no easy task, and it took most of the year to accomplish. However, it has proven to be necessary and welcome change, allowing us to embrace current research and increase our understanding of pre-hospital emergency care. This change, in conjunction with new staff and leadership, allowed our division to change its focus to one that is more evidence-based and patient-driven. Not only do these changes allow us to collect, interpret, and share an increasing amount of pre-hospital data, but they also provide us leverage for updating division protocols and policies that reflect best national practice standards. With the backing of Dr. Christopher Lyon, we are confident that these new changes will ensure that Kern County stays on the forefront of pre-hospital emergency care. As you heard from George Baker, one major area of focus that has been put into practice in 2017 and 2018 are improvements to cardiac resuscitation procedures. The division is looking to leaders nationwide to help guide us in the development of cardiac resuscitation guidelines designed to improve patient survivability. It is our goal to turn Kern County into a heart-smart community. This past year, the division has taken the following steps towards this goal. We collaborated with community partners to conduct a sidewalk CPR week, provided hands-only CPR training to Kern County government employees, provided hands-only CPR training out in the community on numerous occasions, added Stop the Bleed training to local schools, hosted a resuscitation academy here at the Department of Public Health, and in total, we trained over 800 people in hands-only CPR in 2017. While the focus of clinical and cardiac care is certainly at the top of the division priority list, community education is also a priority. Using data submitted by EMS providers and hospital specialty care centers, the division is focusing our attention on identifying trends and opportunities to improve the health and safety of the community. The division has been working with stakeholder and partner agencies to plan community intervention projects in Kern County. One of these projects started in 2016. Using available trauma data, we determined that children who were victims of car accidents were being injured due to the improper or no child safety restraints. The Trauma Evaluation Committee took on this issue and conducted a car seat safety check event from March 4th to March 11th, 2017. This took months of planning and coordination with Hall Ambulance Service, Inc., Kern Medical, Car Seat 101, and the California Highway Patrol. This event included 42 hours of lecture and hands-on instruction and culminated in 86 car seats being checked for proper installation and 28 car seats being given to families in need. Additionally, 2 EMS staff members, Kim Tollison and George Baker, received National Child Passenger Safety Technician certificates. In addition to cardiac and pediatric interventions, EMS is also paying close attention to the ever-changing landscape of EMS systems across the country and especially in California. We have been reviewing our policies, procedures, and protocols in an effort to identify areas that can be updated to affect a positive change in the field. One example is the ALS to BLS handoff protocol that was initiated in November of 2017 to allow paramedics to hand patients off to EMT crews for transport, thus freeing the paramedic to respond to higher priority calls. The constant theme that runs through EMS is quality improvement. We strive to improve our system in an effort to better serve the people of Kern County. This can be seen in our new mandatory background check for any person who obtains a local accreditation, in our participation in the CARES Cardiac Arrest Registry, in our quarterly day-long QI meetings, in our participation in a year-long QI course, and in our eagerness to work with our stakeholders and community to improve every facet of emergency medical services. That concludes my report. I'm available for any questions.
Thank you, Mr. Ferris. Any questions or comments about that from the public? How about from members of the board? Thank you, that was very thorough. Is there a motion then to receive and file this report? Thank you. We have a motion and a second. Please say aye if you support that. Aye. Anybody opposed? We push buttons at the Board of Supervisors. I'm sorry that I'm in the pushing buttons mode. Okay, board member announcements or reports. Do any members of the board wish to say anything or make a report to us this afternoon?
Mr. Chair?
Mr. Surface, yes.
I just want to thank the county fire department and the city fire department for coming on board with the electronic health record system. It's been a huge project for both of them to join. We've also got our friends at Dignity Health. All three of their facilities are now on board. The Heart Hospital's on board. And I think that the data that we're going to start collecting, or that we've started collecting, will really lend itself well to the idea of quality improvement for our system. And Adventist Health will be next. They've made the commitment to join, and then the only one left after that will be Kern Medical. But it's a big deal. The CARES system that Mr. Ferris spoke of will be electronic. There won't be any hand entry, so it'll all come straight out of the records. So it's a good step forward. It's cost a lot of time, energy, and money. The fire guys were fortunate enough to get a grant, which really helped out, and they worked together. They went to bid together, and it's been a joint project all the way. I think it's a big deal for our community, and want to make sure they get some credit for that.
Good. Thank you for sharing
If
that.
I
Chief?
may tag on to that, John and I have been talking, and the goal of the system is the first person on scene starts the report, ambulance, transport, the information goes across, and then it'll go right into the hospital. So the patient care record starts at the beginning of the call and goes right into the hospital. So the record is there, and then there's follow-up, right, John? And being
Yeah.
able to do an after-action report on what happened with your call.
Right, so the last segment of that is the discharge or outcome report that we get back now. And we've got ESO, the vendor that was selected for this, working now on how to get the outcome report back to the first responder. Nobody in the nation ever asked them to do that before. I'm like, well, they're starting the report, they should get to see that data. And so we're working on that, and then one of the largest health insurance organizations in the state has asked for them to get a link to their customers, so they would get everything from, they don't ever get to see first responder reports. They seldom get to see the transport report. They certainly don't see the outcome. The paramedics now are getting a report card that tells them what happened, and so they have the primary impression of the paramedic, but then they have the primary impression of the physician, and then the actual outcome. And so they can say, "Oh, wow, I missed that," or "Wow, I was spot on with that, with my treatment plan in the field." So we've never had that ability before. At the push of a button, it's always been call the hospital and get told it's a HIPAA violation to tell you what it is, and fight through that whole thing. And so it's a big deal. It is the largest public-private partnership in the nation right now for health data exchange. It's not a true health data exchange. That's coming next, right? The department will have some work to do there. There's some grant money here, about $40 million coming towards the state, and that's the next big step. But as far as sharing health information back and forth, it's been a big project, and it'll bear some fruit in the end.
Good, thank you.
Mr. Chairman?
Yes, sir. Mr. Peters?
I'm sure I speak on behalf of all the hospitals and hopefully on behalf of this board in sending our thoughts and prayers and well wishes to Mayor Hall and family as they go through whatever they're going through at this point. So
Thank you.
please let him know.
I appreciate you saying that, because that was the next thing on my list to say as well,
okay.
that we...
Sorry.
No, it's great. I'm glad you did, because it just demonstrates the breadth of our concern. So we are hopeful that he fully recovers, and that I know there's a lot of stress on he and Levon. So please assure them that we are thinking of them and
Thank
praying
you.
for them.
Thank you.
And all the staff. It's not an easy time for your staff either, probably. I have, so thank you for saying that. I have one other thing to bring up. We discussed at the Board of Supervisors last Tuesday the issue of opioid addiction and abuse, and the concern that we have for it, and how, what can we as a community do to help with that. And a question was raised at that hearing about the use of Narcan. I'm in a room full of people that have seen Narcan used many times. I've only seen it used twice, but it was dramatic to the first time. Then Battalion Chief Gary Hutton and I were on a ride, and he said, "Watch this guy, he's going to rise from the dead." And he did. He just jumped off that bed, and levitated almost. So it is dramatic what it can do. And this is why I brought that up. There are some places back east where Narcan, or you would know probably, but I can't remember. It's a long name for the generic that narcoflaxin or something like that. Naloxone. Thank you. That it is made available without prescription to the families of those who are the abuser, so that when the family member comes across their family member who has overdosed, they can immediately administer the counteragent, and it's saving lives. We do not do that here. I'm interested if anybody here has an opinion about, or any perspective on whether or not that is something that we might pursue in Kern County. And the health department's going to look into it, but does anybody else here have an opinion or a thought about that?
I think it would be a great idea to explore.
Okay.
I'll have to double check, but I thought they were making it over the counter. I'm pretty sure that's been pushed through at the state, but I have to double check.
I know there have been several laws, regulations passed at the state level that allow physicians to, it actually encourages physicians to provide naloxone to family members of patients that are known to take opioid drugs.
The state is exploring that, whether or not they want to make that recommendation, or they have already?
They have already done so. I'll find the case numbers
Okay.
for you.
Great.
I think one of the things you're seeing on the East Coast is that they're just making it readily available. You don't have to have a prescription. That was the big difference on the East Coast versus what's in California right now. In California, you have to have a physician that writes a prescription. You go buy it over the counter. It's a couple of dollars per vial. It's not expensive at all. But it comes and goes. By the way, Narcan, we all know at least once a year, Narcan is no longer available.
Oh, it's
Everything is
used up?
Well, the manufacturers don't make enough. And about once a year, we go on a shortage, and we try to forecast when that shortage is going to be and make sure we have plenty on the shelf, because it can be tough to get our hands on. But it's an ongoing problem. Kern County, actually, the hospitals here locally should get some credit for what they did 3 years ago. The doctors all got together and said, we're going to quit giving people opioids in the ER that come in looking for it. And so we have people that call us and go from hospital to hospital looking for their next fix, and they get to the next hospital and they still don't get it, and they walk outside, call 911, we take them to another hospital and they still don't get it, right? So the hospitals made that commitment a few years ago when the problem was getting worse here. And you have, the problem is a lot of these are prescribed opioids. Family member goes to their doctor and gets 60 pills and shares it with their friends, and then you've also got the heroin that's in town and different stuff. So it's a huge problem. And there are some significant behavioral issues that happen with some of these people when you wake them up.
Yeah, they're not in a good mood.
You need
right?
you need law enforcement intervention when you wake them up, because they spent their last dime on their fix, and you just ruined their high, and they don't realize they weren't breathing for 2 minutes before you got there. So it is a significant problem, and there's a lot of different ways we've got to tackle this, but certainly getting Narcan into the hands of some family members is probably not a bad idea.
So we also, it's now basic scope for EMTs,
That's
as
right.
well as an optional scope for some of the law enforcement agencies that have started carrying it. AB 1535 was passed in 2015, I guess, and that made naloxone available without a prescription from the pharmacies. So that is in effect in California now. I just wanted to confirm that is. So, and maybe that's something we need to work on, is communicating that
Right.
to families. And then, one of the other things that I had thought of was if we have patients that wake up from Narcan and sign out against medical advice, whether there's some way we can provide them with some information for them and their families on how to get this, as well as to seek help with their addiction. So I definitely think there is room for improvement that we can all work together on.
I think you would be shocked to look at a zip code map on where the calls are. They're not in the parts of town where you think they would be. They are in some very affluent neighborhoods where people have access, easy access, and you roll into some really, really nice gated communities for these calls.
Well, if any members of MCAB or anybody in this room has ideas or suggestions for us, please run them through Mr. Ferris or whoever, however to get them to me so that we can make sure they're part of our strategy to do something about this, because it's clearly, it's amongst us, taking those we love, so we want to do something about it. Thank you, I appreciate that. That's great discussion. Anybody else? Okay, I need to make two announcements at the end of the meeting. Our next regularly scheduled meeting is for Thursday, August 9, 4 p.m. in this room, and the deadline for submitting a public request on that agenda is Thursday, July 26th, 5 p.m. here in this building. So, any other matters before us this afternoon? Is there a motion that we adjourn then? Thank you. Without objection, so ordered. Thank you very much, everybody. We'll see you in a month.